So now that you've explained it to us, why wouldn't we collect enrolled patient charge data from our pivotal study sites? I can still remember talking with this client before she was a client, and the conversation had started out something like this. So she came to us and said, can you help us add some economic endpoints to our study? But we don't want to add too many endpoints because our case report forms are already complicated. We're already asking a lot of the sites, so on and so forth. They wanted to collect economic data, but they were worried about what it was going to do to the study. So I suggested that let's not mess with that. Let's just collect the billing data and avoid doing anything with the study protocol or with the CRFs. And so again, I can still remember the response. It was, what? You can do that? We didn't know that that was a thing. But how would you do that? I'm just not sure, that that's the way to go. And so it kind of went back and forth like that for quite some time. But by the time I was done explaining to her, this was the response. Well, now that you've explained it, why wouldn't we do that? And what I'm really hoping is that by the time you reach the end of this webinar, that you feel the same way. And that quote just really sets up why we're here. So we're here to learn how to maximize regulatory studies, but really any study, to help you support market access. So it doesn't really matter whether you're in the pre-approval phases or your product's already out on the market. If you're conducting a study that involves sites, physicians, and patients, collecting billing data is a smart thing to do. So first of all, let me just introduce myself to you before we really get started. My name is Beth Brooks, and I'm the Executive Vice President of Global Commercialization Services for TTI Health Research and Economics. Now, I kind of like that title, EVP of Global Commercialization Services, because it kind of sounds important, but I also kind of don't like the title because it doesn't really tell you anything about me. So let me give you a little bit of background. I'm a mathematician by training, but I've been working as a health economist for the last couple of decades. So until this year, I got to say that I've been working as a health economist for the better part of 2 decades. But I realized just this morning, actually, that now I have to knock it up to the 2 full decades. So I guess that's good from an experience perspective, but it really makes me feel ever so much older somehow. But aside from that, putting that aside for a minute, for the last 13 years of that experience, my health economics and market access work has really been focused on the medical device and diagnostics industry. So for that whole time, that last 13 years in particular, I've been talking about how important it is to collect market access focused data, health economics data, during any planned clinical studies. And in talking about that, really one of the easiest ways to do that, to collect that health economics data, is one of the least utilized ways of doing that. And that's through the collection of billing data from your sites. So that's what we're here to talk about today. And hopefully, again, we'll make you an equally big fan of billing data collection while we're at it. So what's our agenda for the discussion today? So I always like to start out by setting the stage. And a good way to do that is through an analogy that most of us can either directly relate to or at least appreciate in some way. And so that's how we'll get started today. And then after setting the stage, I'd like to talk about billing data collection from big picture to little picture. So generally, what are we talking about and what can we get from it? And then specifically, what are we talking about? What's billing data? What does it look like? So that you know the big idea and then the details of it. And then next thing we'll talk about are the objections. So I've heard lots of objections to collecting billing data. Most of them fall into the category of, I hear you, but here's how we can make it work. So they come up with an objection and, okay, yep, valid objection, but here's how it actually works. So we'll talk through all of that as well. And then probably what a lot of you will really want to hear are some case studies. So how did we make it work for 4 different clients facing 4 very different scenarios? And then the next step is to let you know what those clients said, after we'd worked for them, and what some other clients have said about our work as well and how it helped them. Finally, we'll hit the key takeaways, and there are just a few in this case. And then answer questions. Hope we'll have plenty of time at the end to really hit on those questions and provide some answers for you. So here's the analogy. Seemingly as far away from billing data collection as you can get, but I think it works. So let's suppose you're renovating your kitchen. And let's suppose for a second that you're not just doing a little minor renovation, but you're doing a major overhaul. So you want to redesign everything. You want to relocate stuff. You want to move the sink by the window. You want to move the stove to a new island. You want to change from hardwood floors to tile. So what if you hired the contractor and the contractor said, okay, what we're going to do is we're going to put in all your flooring first. And then once we figure out how we want to move the appliances around and where we want to put the island and all of that, we're going to rip it all back up and then put the new stuff in, move it around, and then replace the floor again. So what would you say if that was what your contractor said when you're renovating your kitchen? You'd say, are you out of your mind? Of course, that's what you'd say. So the question is this: why is it often the mentality to do this exact thing when you're thinking about your clinical studies? So why do you think about just collecting the clinical data first and postponing any discussion of collecting economic data until after those studies are finished? Why do you want to think about it in that way? Think about it every time you're having a conversation about your clinical studies or any study that you're going to execute. How can I maximize my studies to serve multiple purposes? They're expensive. Make the most out of them. Don't do one thing at a time, and ensure the need for multiple studies to really improve your market access. So with that as the backdrop, let's talk a little bit about the big picture. What are you getting if you collect billing data during your studies? So what we're going to look at is the big picture is going to be the staircase that we're building to market access. So by collecting billing data, will you have everything you need to ensure positive coverage decisions and 100% facility adoption from the word go? Well, of course you won't. I mean, that's just silly. You won't have your entire health economics evidence base, but it's going to give you a start. It's going to give you some evidence based on use of your technology by actual facilities, by actual physicians, and actual patients. Not just how it works clinically, but what are the economics associated with it. So is it perfect? No, it's not perfect, but is it better than nothing? Well, it's lots and lots better than nothing. So if we kind of continue in this vein, if you're able to gather further information on the use of competing technologies at those facilities that you were utilizing for your pivotal study or for the other clinical study you might be conducting, or at different facilities. If you can get facility information through billing data, you'll have information then on facility resources associated with your procedure and with the appropriate comparator procedures if there are any. So again, is it perfect? No, but at every step you're getting closer. So that's really the big picture, is that by collecting billing data within your studies, you can be getting closer to that evidence that you really need that will help you at launch with your market access. It'll help improve market access for your technologies that are already out in the marketplace. And it may not be perfect. There may still be other studies that have to be conducted in the future, but you'll be able to get quite a bit of mileage out of it. So now that we've talked about the big picture, so what are we trying to do in the scheme of things, let's talk specifically, what are we talking about when we speak of billing data? So there's actually 2 different forms that we're talking about, and I'm going to just walk you through them one at a time. So the first one is the CMS 1500 or the HCFA 1500 form. And it's, if you see the paper form, it's actually red ink on white paper. It's the standard claim form that's used by physicians and suppliers for billing claims. So I typically think of this form as this is the form for the people providing medical care. So it's the physicians, the PAs, the nurse practitioners, the midwives, the psychologists, the social workers. You'll also see things like equipment suppliers, ambulance services, and laboratory services. They also use this form. So really the key is that it's used by non-institutional providers, but I typically think of it as the people form, just to simplify it. So what does the form look like? So this is a shot of the top half, really, of the one-page HCFA 1500 form. And I've blown it up a little bit over 2 slides just so you can see it a little bit better. But if you look at it, what's being gathered on this form? You know, you've got basic details about the patient's address, the patient's name. You've got basic information about the insurance, what type of insurance, what's the ID number, who is the insured, is it the patient or is it a family member? Are there circumstances like injury on the job or an automobile accident that might make another insurance provider the primary, like workers' compensation or auto insurance or something like that? So that's kind of the basic information that's on, you know, the top part of the form. And then on the next part of the form, you see more information about what the patient's being treated for, so the patient's condition, and what are the actual services that are provided. So you see a big section here about the diagnosis or nature of illness or injury in this block 21. So there's a place to add lots of diagnosis codes, ICD diagnosis codes. You see information about the dates related to the service, if there was a hospitalization prior, you know, when was that patient hospitalized? You know, is there a resubmission code? Is there a prior authorization number? So many services, the insurer has to provide a prior authorization or they won't pay the claim. But then below you have, you know, a place where you just list the procedures that were provided. So the dates of the service, what was done or what supply was used. So there's places for the CPT codes to go there. There's a place where it points back to the diagnosis codes that were provided, and then the charges are listed. And so basically you're just getting everything that was done to that patient summed up on this form. And if there was an anesthesiologist involved and a surgeon involved, each medical provider would submit their own HCFA 1500 form for that patient. So that just gives you an idea of the information that's collected and the information that could be gathered on each of your patients in your study. So now let's take a look at the second type of billing form. So the UB04 billing form is the institutional billing form. So I talked about the other form as thinking people. For this one, I think places. So this form can be used by any institution that's providing services. It can be a regular hospital, it can be a dialysis center, it can be a home health agency, it could be a skilled nursing facility. This is the form that they're going to use to send out their charges and submit their claims for services to the payers. So if we go to the next slide, again, this is in paper form. It's the red ink on white paper form as well. But here, you know, we just have a screenshot, again, broken out over a couple of slides that shows you the information that's collected. So again, this first view shows you basic information is entered, and the blank spaces up here, that's information about the hospital or other institution. And then there's information about the patient, again, name, address, birth date, further information about the facility. There are places to provide condition codes or additional codes, things that would show transfer from another hospital, for example, or again, automobile accident, codes like that that give the payer information it needs to process the claim. But in this case, you start kind of at the top of the form listing the specific things that were done to the patient. So here you'll see this listing at the bottom under items 42, 43, and 44, so on and so forth, the revenue code. So that's a place where different line items for things like cardiology, emergency room, operating room services, pathology, pharmacy, laboratory, all those things, those items would be listed separately and associated with the appropriate revenue code. Again, the appropriate HCPCS codes would be listed here, service dates, service units, and total charges. So what you can see clearly is that everything that's being billed to the payer is going to be listed here in gory detail. So if you collect these data from your participating study sites, you're getting a lot of information on exactly what happened to each patient enrolled in your study. So here's the bottom half of the form. So in this case, it's just organized differently than the HCFA 1500 form. I don't know why, but it is just organized differently. Here's where you'll see information about the payer name, the ID number, have there been any prior payments made, and then, you know, who's the insured party again, what's the group name, all of that information. Again, treatment authorization codes. So if there were certain procedures being performed or the hospitalization required authorization from the payer, that's where those codes could be entered. And then here, beginning in area 66, you see all these places where you can list diagnosis codes. So again, you know, what diagnoses does this patient have? What was the admitting diagnosis? So why are they there? You know, they might have a number of different diagnoses, but why are they there? What's the admitting diagnosis? If there were multiple procedures performed, what was the principal procedure? Because this is going to affect how the payer pays for that claim. What other procedures were performed? So again, there's a lot of information there, and you can see if you're collecting this data on your patients, there's a lot of valuable information that could be included in analysis of your study data. So finally, before we get out of what I consider to be the most boring part of the presentation, each hospital actually has a charge master file. So it's a list of all the billable services and items that it may provide. So it captures costs of each procedure, each service, each supply, everything that could be done at the hospital or another facility, as well as any fees associated with those services. So their equipment fees, room charges, things like that. So everything that that hospital does, there's a charge master file that the hospital has that details information about that and how much they charge for it. So the reason we're talking about this at all is because sometimes, not very often, but sometimes an institution will not have generated a UB04 form. So for example, if the study sponsor paid for all of the services rendered to the patient, they might not issue the UB04 form, even though they usually do, because it's just a standard operating procedure within the hospitals. But even if they don't, they will always have a listing of services and supplies provided in some sort of listing that was derived from the charge master. So what I'm showing you right here is just a little snippet of a charge master. It shows you, again, items that are listed. You would have, the different levels of emergency room visits that are possible, the corresponding CPT codes, and then what that hospital charges. Again, we have just a little snippet of laboratory and pathology services as well. Again, the point is that every single thing that they do, every single procedure or service that is provided is on the charge master with the appropriate codes associated with it and the appropriate charges. And typically the UB04 form is prepared just by cutting and pasting from the charge master. So again, occasionally when we're conducting one of these billing studies, a site might not have UB04 forms for all their patients, but they will have some sort of a snippet from the charge master that shows exactly what services and supplies were used for that patient. Okay. So now that you have an idea of what we're talking about when we talk about collecting billing data, I wanted to show you the 6 most common objections that we hear when we start talking about billing data collection with our prospective clients. So the first one that should pop up here in a second, hang on, okay. Our study is underway and we didn't plan to collect billing data. So the perception here is that, what can we do? We've already started our study. I hear you. We should have collected billing data. We didn't plan for it. And now what can we do? So really the solution to that is pretty simple. And in most cases is pretty easy to resolve. You can generate new informed consents, and site contracts can be developed that permit collecting those data after the fact. So it's underway, but you can still make adjustments to the study, get those informed consents and contracts in place, and then proceed with collecting the billing data. So that's usually a pretty easy thing to address. So another very common objection that we hear is that our clinical study coordinators say they've never collected billing data and they have no idea how to handle this. So again, this is one we hear very, very commonly. Our CSC or multiple CSCs at the different sites are really, really good. They've got everything nailed in terms of the clinical protocol and execution of that protocol, but they have never conducted or participated in collecting billing data. And so they have no idea how to go about doing that. And again, the two groups are often really siloed. So your clinical study coordinators may not know anybody in the billing department. They may not know anything about how that works. And so they are fearful of that. But that's something that we have experience with, and many other vendors have experience with that. The solution is just to help them liaise with the billing department, work your way through to the billing department, help them, and even take it over for them. Sometimes they don't even have to touch it. You can just work directly with billing and get that data, and they don't have to really have a thing to do with it. So our sites are already overburdened, and we don't want to add anything to their plates. So again, this is extremely common. I probably said that for each one of these, and we'll continue to say that. But it's very common, and we get that. We get that conducting a clinical protocol is difficult, that many of the protocols can actually be quite complex, and you feel like your sites just can't handle anything else, and you don't want to add anything else to their plates. But again, kind of related to objection number 2 about the clinical study coordinators, if you go about it the right way, you're really not adding anything to their plates. You can make it easy for them. You can interface directly with the billing departments. You can help them form that liaison channel. It can really be very, very simple if you know what you're doing and you go about it in the right way. So the next objection that we hear very frequently, and it's very true, is that our sites or some of our sites will not agree to provide billing data, regardless of whether the patient says they're okay with it or not. And, that's true. I mean, there are some sites that won't provide billing data, but most of them will. So in our experience, you can get data from 75% of your sites. There are always a few that don't want to give the data. There are occasionally some who just they could provide the data, but they really just don't want to for whatever reason. They believe that it's difficult, even though you show them that it's not, so on and so forth. So for some of them, you just let it go. But for most sites, it's pretty easy to get the billing data, again, if you go about it the right way. And our next couple of objections here, I don't see what good it'll do us to collect billing data if we're only enrolling a single-arm study. So, basically the objection is saying, if I don't have comparative data, what's the point? So for this one, just keep listening, and we're going to hit on this one in detail. And, the final objection here is really one that says, our pivotal study or whatever study it is that we're talking about is long since completed. So our train's left the station. So that's not really true either. So again, keep listening. We're going to talk about this one in a case study too. Okay, so after all of that, as backdrop, we're really ready to talk through our case studies here. And the first one we've called establishing value. So what's the scenario we were facing here? So here we had a client with a minimally invasive procedure for a women's health concern. And what situation were they facing? They really had a pivotal study that was almost completed, but it was a single arm study only. They had actually thought ahead, and they had made a provision with their patient-informed consent and with their site contracts for the collection of billing data, but they hadn't done anything about it. They really hadn't gone about trying to collect the billing data, because somewhere along the line, they thought, well, we only have a single arm study. What is it really going to help us with if we don't have comparative procedures? But on the other hand, we don't have any economic evidence. We have a category 3 CPT code that, is great. It's a step along the pathway of getting our category 1 CPT code. We know that, it's payer established payment levels. We just really don't have any economic evidence. So what are we going to do? I mean, they were kind of in a getting panicky kind of situation about how to develop that evidence. And so what we did for them was really to, kind of sit back and figure out what's the best way that we can get some economic stories spinning out for them. So we actually designed 3 distinct study efforts, which hinged on, number one, we were collecting billing data from the pivotal study on the client's procedure. So again, in this case, it was pretty easy. They had already, had the foresight to at least put the appropriate language in the informed consent, put the appropriate language in the site contracts that billing data could be collected from the patient. So that part was done. So we needed to collect that data, but then what are we going to do about the competing procedure data? So we really went about that 2 different ways. One was we designed a retrospective case match study to obtain billing data on competing procedures at those same pivotal study sites. So we would have data we'd have billing data from the client's procedure. Through the retrospective case match study, we would get billing data at those same sites on the competing procedures, so we could make direct comparisons there. But we also wanted to know more from a payer perspective, longer term, what actually happened to the competing procedure patients over the longer term. We were collecting data, or our client was collecting data over the longer term in their clinical study that we could use to get that economic information from our client's study procedure. But we wanted to get that information on the competing procedures as well. So we also at the same time conducted an administrative claims database analysis to look at that longer term data. So the outcome of all of this, we started all 3 of these things at the same time. The outcome was that we've had 3 peer-reviewed manuscripts developed. They've been prepared and submitted for publication. So it's spinning a couple of different stories, both facility perspective, economic and clinical analysis, as well as a payer perspective economic analysis. And each of those really established the new technology's value as best it could be established very early on, that it's resulting in lower costs from the facility perspective. It's resulting in improved outcomes from a short-term and a longer-term perspective. That story is fleshing out really nicely. And we have it, again, from both facility and payer perspectives, which is really important. So this client's really hitting the market with the best data they could have at the launch of their technology. So the next case study we're titling Compelling Value Analysis Committee Arguments. And here what we're talking about is something very different. So a very different kind of technology, a very different scenario from what we were facing with the first case study. So in this case, we had a client with a technology that was intended to predict when a patient could be safely removed from mechanical ventilation. So this is for patients who are obviously very seriously ill. They're in an intensive care unit. They have been placed on mechanical ventilation, which I think just about everybody understands is a very costly intervention for patient care. And this technology could be used to say, okay, this patient could be safely removed from the mechanical ventilation and probably not have to have the mechanical ventilation started again. And this patient can't. They need to stay on the mechanical ventilation a little bit longer. So the situation that they came to us with was that an RCT had been conducted, and it showed a reduction in the mechanical ventilation days, but not in overall ICU length of stay. So that was something that they really hadn't expected. They'd expected to see a reduction in the mechanical ventilation days and a corresponding reduction in the overall ICU length of stay, but they had not seen that. So that was a little bit of a surprise, and not, a great surprise, obviously. But in conducting this study, they had really not looked at any other costs associated with their technology or with the overall hospital stay. And what they needed was to create a compelling value analysis committee argument, or VAC argument. But to do that, they had planned to base the argument on this ICU length of stay, which is pretty well known. ICU care is more costly than step-down care. And when that was taken away from them, they really needed to understand the cost of the mechanical ventilation as a component of the ICU day. And they really needed it not for the whole mechanical ventilation time, but just for the subsequent mechanical ventilation days, because these patients still went through the start of the mechanical ventilation, which is really the most expensive time. And there wasn't any good data in the literature for them. So given that scenario, we went back and proposed just a simple protocol and an additional informed consent process that was successful in permitting collection of billing data for about 60% of the enrolled patients in both study arms. So we were able to go back, and these same patients in the study look at their billing data and see what was being billed. And ultimately what we found was that the billing data showed a reduced cost of the subsequent mechanical ventilation days. And even without a reduced overall length of stay, the cost reduction that they were able to realize by removing that ventilation time was compelling, and it was supportive of the new technology pricing. So they were able to obtain that data, put it into their value analysis committee models, and move forward with that. So our third case study is a little bit different. So this is one we call differentiating a commodity. So what was the situation here? So here our client had a surgical supply that was used in laparoscopic surgical procedures. And what was the situation they were facing? They were facing a scenario where their supply had become commoditized, which is really what nobody wants to have happen to their technology. It had become a commodity. The purchasers within the hospitals were saying, there's a whole bunch of different manufacturers that provide this supply. We're just going to choose the one with the lowest costs. That wasn't our client's technology, and they had reason to believe from their bench studies, from other qualitative research studies that they conducted, that their supply should be associated with reduced hospital costs due to superior performance, due to better visibility during the surgical procedures, resulting in fewer complications, resulting in reduced operating room time, things like that. So In this case, there was no pivotal study that had been conducted. There was no clinical study that had ever been conducted, kind of comparing this client supply with a comparator. So in this case, what we did is we identified some facilities that we knew were using our client supply, as well as some of the comparator supplies. And we designed a simple protocol. Again, a retrospective case match study was conducted, where we just collected the billing data for those patients. So again, collection of the billing data, if you'll recall looking at the UB04 form in particular, where all of the details were able to be captured there about operating room services, blood and blood components, respiratory services, laboratory, radiology, all those different billing and revenue codes are listed there. So we could really create quite a nice story out of the patterns that we saw in the data. And so ultimately, we were able to determine that use of the client supply did lead to reduced OR time, reduced time in recovery, reduced medication costs. And again, from that, we were able to create a compelling value analysis committee argument and help them move away from that commodity and pure price discussion to a discussion of value. So finally, our last case study is also a little bit different. The case for carve-out payments is what we're causing this. I'm noting that, these are sounding like, mystery episodes or something, the case for carve-out payments. That's neither here nor there. But anyway, so for this particular case, this again was a surgical supply. In this case, it was used in abdominal procedures for a specific subset of patients. So if I'm remembering correctly, in this case study, there was certain patients who would tend to be more complicated. They had specific anatomical features that made their cases more difficult, made the surgical procedures more difficult. So the client in this case was planning a pivotal RCT, but they were interested also in understanding longer-term cost implications in a scenario where a specific surgical supply type would not be identifiable in a future claims analysis. So let's say, if this was, and this is not the technology, but let's say it was a laparoscopic procedure and it was using one trocar type versus another manufacturer's trocar type. That's not something that in a future claims analysis you're ever going to see. You're not going to see the trocar type that was used. Again, just as an example. So claims database analyses are not going to do you any good. You can't figure out what the specific supplies were. Sometimes with something like the Premier Hospital data, you can tease some of that information out. Sometimes you can't. But ultimately, what they really wanted was to create a payer argument for additional carve-out payment for their technology. So they were falling in a certain DRG. Their supply was not getting separate payment. But if they could create a good argument for the payer to say, in the future, this is going to reduce costs for you, you can create an argument to the payer that says you should carve out this technology and pay us more for it if we can give you the evidence to do that. So that's the situation that we were facing here. So our solution was to provide that appropriate informed consent and site contract language to enable collection of billing data from the index procedure site, but also from affiliated outpatient sites for a period of 12 months post-procedure. So that we were going to get that data from the index procedure, but we also, again, were interested in that longer-term payer perspective story. So we also wanted to know that we could get it from these affiliated outpatient sites so that we could build that longer-term story. So again, what was the outcome? While not all the study sites were able to provide that longer-term data, about 70% of them were. So we were able to get that information regarding reductions in longer-term medical resource utilization due to that client's surgical supply that truly did make their longer-term outcome better. And since we executed this study, hospitals have been able to use those data that we packaged for them to obtain carve-out payments for use of that technology in appropriate patient populations. So again, kind of an unusual twist on how that billing data collection could be used, and also the extent to which billing data can be utilized. So again, not just for an index procedure, but over a period of time from multiple different sites. Okay, so now, what have our clients had to say about us, for these and, some other opportunities? It's really projecting that same notion that I talked about, as I went through the objections, is that, we have a can-do attitude. We also understand long-term vision, but short-term budgetary implications. So we see the big picture of where you're going, and we see the little steps that you can, that our clients can take to let them get there. In whatever way they need to. Budget small, we can work with that. We need to take 4 incremental steps to get to the big picture, we can do that. So that's something that we really pride ourselves in. So, again, this really speaks to the can-do attitude. Culture's important. They're get-it-done kind of people. That's really what we're about. Again, there are objections, there's obstacles, there's pitfalls, there's things that derail projects. We all know that. The important thing is to keep going and to find solutions and not focus on the obstacles. This is probably my favorite quote of all time, that if we could go back in time, we'd hire TTI 2 years ago. So this was a client who came to us after they had kind of made some of these mistakes, not collecting the economic data early on, going about the wrong type of analysis. And, when we were able to help them improve their market access moving forward, they said, gosh, we wish we could have hired you 2 years ago. And, that's a really powerful thing to say that we really appreciated. And then finally, and this is one of our clients that we did one of the billing data collection studies for, they would say it made 100% improvement in their ability to get the product past the value analysis stage. Again, it can be simple, the things that you need to do to get the evidence that facilities or payers need to make those decisions. And there's a lot of different ways to get there. And, that's, again, really what we try to see is we try to see the opportunities and not focus on the barriers. Okay, so finally, and I feel like I've been rambling for a long time. I hope you don't feel like I've been rambling for a long time, but what are the key takeaways that we want you to take from this webinar today? So not collecting billing data. If you're not collecting billing data, you're really missing an opportunity to build your technology's value proposition. It's an easy thing to do. It's not 100% successful because not 100% of sites can provide it, but it works really well. It's really simple, and you can build powerful stories from it. Don't renovate the kitchen twice. Again, it's a simple little analogy, but I think it's one that resonates. You wouldn't do that. You wouldn't renovate your kitchen twice. You wouldn't put the flooring down and then rip it up to move the appliances and then put the flooring down again. So don't do that with your studies. Collect everything that you need at the same time. And again, it's not to say that you won't have to conduct multiple studies over time, but don't conduct multiple studies for that reason, because you just didn't collect the economic data that you needed. And then finally, retrospective billing data collection. Even if you don't have a prospective pivotal study, there's a lot that you can do with billing data collected retrospectively from facilities that you can enroll for that purpose. For collecting data on your procedure if it's in use at a facility, and or for competing procedures, it's also a great way to build your health economic story. It's a whole lot simpler and a lot less expensive than a prospective study. So it's an important option to consider. So those are the key takeaways. I am now very happy to answer any questions that you might have. I think we'll have a little bit of time left to do that. So thank you so much. So I would love to answer any questions that you have. I have gotten a couple during the course of the presentation, and we can go through those, but I would love to hear any new questions that you might have at this point. So while I'm waiting for those, maybe I'll just talk through the questions that I've gotten so far. The first one was just, will we receive a copy of the webinar and slides afterwards? And yes, you will. You'll be automatically emailed the recording as soon as it processes, so that'll come over pretty soon after the webinar ends. And I'm also very happy to send the slides to anybody who asks for the slides. So just shoot us a note and we'll be happy to provide just the slides back to you, and you can always go back through the webinar when you get that recording of it at the end. Next question that we have gotten is, I think, a great question. How do you comply with the HIPAA regulations? And obviously this is a huge concern. And in most cases, we handle that by just requiring the facilities to de-identify the billing records before they come over to us. So to take away any of the patient identifying information before they send it over to us. So if it's in a clinical study, what we're doing is just asking them to record only the patient identification number from the study and taking out any of the other information, so we never see it. In other cases, we have signed business associate agreements with the sites so that we can receive that data and they know that it's being handled properly through, we have the secure fax lines, the secure email transmissions, we have the locked cabinets in our offices, etc. All the things that would be necessary for us to be in that BA agreement with the sites. So I do see a new question that has come in. And the question is, for medical device that is not yet FDA cleared or reimbursed, one inserted without surgery in an office procedure, so what billing data is available? So in that case, there we're talking about an in-office procedure. There would still be the HCFA 1500 form that would be generated, even for a device that's not FDA cleared. That HCFA 1500 form would be generated. We have worked with physician office sites, however, that are in the scenario that I described briefly when we talked about the charge master files, where the medical device company is actually paid for everything to do with the study, and so maybe they didn't generate their typical HCFA 1500 form. They always have records of supplies and procedures and costs associated with those, typical charges associated with those. So you can still get access to information that you need. Are there any other questions? Again, happy to answer anything else. Or of course, if you think of a question later, after you have time to process a little bit, again, reach out to us on the next slide. When we get to it, my contact information will be there. You'll have my direct email address, and I'm very happy to answer any one-off questions if you reach out to me. So we'll wait just another minute here and see if another question comes through. Okay. Nothing else so far. So I think we'll just go ahead and go to ending the webinar. I appreciate your time very much. I'm so glad that you made the time to attend this session with us today. Again, there's my contact information, ebrooks@ttiresearch.com. I'm very happy to speak with any of you, to answer email questions, and hope to hear from you. Thanks so much for attending.